giving the floor to Professor Sophie to start this webinar. We're looking forward for the talk, Sophie.
So, oops. Yeah, first of all, thank you for being here. And so it's a pleasure to talk today about inflammation in heart failure, from mechanisms to therapeutic opportunities. And for that is first of all to know that inflammation is diverse. It can be infectious or sterile. You can distinguish low-grade and high-grade inflammation, as well as acute or chronic inflammation, and also systemic and local inflammation. Now, inflammation is an important trigger of heart failure, whereas heart failure in turn is an important driver of inflammation. So pointing already out the complexity of targeting inflammation in the context of heart failure. And that this is difficult, that we also have learned from previous studies, here now shown by the RECOVER and the Renaissance trial, where they used an anti-TNF-alpha antagonist, etanercept. And why did they do that? Based on the findings that circulating TNF-alpha levels, that they increase by worsening heart failure. Now you can appreciate from the graphs on the left that finally the anti-TNF-alpha treatment led to mixed results. So pointing out that one size does not fit all, and that we need to get further insights into the different phases of inflammation. And let's first start with sterile inflammation here, now after a myocardial infarction, where it's meanwhile well appreciated that you get, after the damage, you get a sequential infiltration of immune cells, which are important for clearing up the cellular debris, allowing collagen production, and further also scar formation. And that inflammation is of relevance that could then also experimentally be shown here. This is in a dog model where they performed myocardial infarction and treated them with methylprednisolone. And you can appreciate here on the right that you have a thin scar, so also with the danger finally for left ventricle wall rupture. Now in this process, cytokines, also interferon gamma, plays an essential role. And you can here now on the left also appreciate that with respect to the impact of interferon gamma on fibroblasts, that here you do not get an induction of collagen, neither you get an increase of alpha smooth muscle actin expression, so no induction of myofibroblast transdifferentiation, though, and if you look now at TGF-beta, profibrotic TGF-beta, then you do see an increase of collagen as well as of myofibroblast transdifferentiation. But if you look at the impact of interferon gamma on chemokine expression, then you can appreciate that interferon gamma supplementation to fibroblasts leads to particularly an increase of chemokines involved by attracting the pro-inflammatory monocytes, so CCL2 and CCL7, and indeed this was also reflected in an increased migration of pro-inflammatory Lysx high towards Lysx low monocytes. So pointing out that immune cells, they trigger fibrosis, but on the other hand also that when we talk about inflammation, this is not only involving immune cells, also, for example, fibroblasts can here be important inflammation supporter cells. Now, where are now those cells coming from? And here I go in an example of chronic ischemic heart failure, where you can appreciate that after myocardial infarction, you get an increase of CD11b F480 cells, and along with that, lower presence of the cells in the spleen, so indicative that those cells homed from the spleen towards the heart. And that the spleen is here so important, that could then also be shown by performing a splenectomy, importantly 8 weeks after myocardial infarction, and this resulted then finally in lower presence of CD11B cells. And also of importance, it did not further lead to a further deterioration of cardiac function, here shown by ejection fraction. Now, in the cardiosplenic axis, interleukin-1 beta plays an essential role, and interleukin-1 beta is released after myocardial infarction and leads in the spleen to monocytosis, what could also be shown in interleukin-1 receptor knockout mice, where you see a lower proliferation of splenic monocytes, and that is then further also again reflected by lower presence of monocytes in the heart, so further supporting the role of interleukin-1 beta in the cardiosplenic axis. But interleukin-1 beta and also upstream NLRP3 inflammasome, they do not only play a role in myocardial infarction, they are also of importance in atherogenesis. And this pointing out that we have a cardiovascular continuum, so that following myocardial infarction, we have cytokines which can further trigger atherosclerosis, which then again can lead to further myocardial infarction. So myocardial infarction begets myocardial infarction. And here are now also recent data showing the existence of so-called trained immunity. And so what they did here, they gave mice with a high-fat diet bone marrow cells from mice which had a myocardial infarction, and then you can appreciate that those mice, they have a more pronounced atherosclerosis compared to the mice which received bone marrow cells from sham-operated mice. Now, the existence of the cardiovascular continuum and the role of interleukin-1 beta in this was then the underlying rationale for the CANTOS trial, so the largest anti-cytokine trial performed. And importantly here, patients were recruited which had still residual inflammatory risk and which had a previous myocardial infarction. And then you can appreciate that the canakinumab resulted in lower cardiovascular events, but importantly, there was no change in overall mortality. And one of the reasons was because it was also associated with an increase in fatal infections, further pointing out the difficulty of targeting inflammation. That led then also to search for alternatives and also upstream to look what is the potential of NLRP3 inhibitors, which are now also under investigation. And intriguingly, colchicine, which is a microtubule polymerization inhibitor and also reduces the migration of immune cells, is a non-specific NLRP3 inflammasome inhibitor. Why? Because it finally inhibits the assembly of the different components of the NLRP3 inflammasome. And here I jump now from sterile inflammation, myocardial infarction, to infections inflammation, here myocarditis, where you can appreciate that there is an increase of inflammasome activity in leukocytes as well as in cardiomyocytes, and going along also with a higher neuroclassification. That inspired us now also to have a look what is now the impact of colchicine in the context of viral myocarditis. And for that, we first infected cardiomyocytes with Coxsackie virus B3 and treated the cells with colchicine. And then you can appreciate that colchicine could reduce the Coxsackie virus-induced apoptosis as well as the viral progeny release, and that this was also associated with lower presence of ASC, caspase 1, and interleukin-1 beta positive cells. Now, in the in vivo context, here we could also demonstrate that colchicine treatment improved the cardiac function in Coxsackie virus B3 infected mice, and importantly that this went along with lower presence of ASC positive, caspase 1, and interleukin-1 beta positive cells in the heart, but not only in the heart, also in the spleen. And the improvement in left ventricle function was also associated with a reduction in cardiac fibrosis, as you can see from the lower collagen 1:3 ratio. Based on these findings, we went then also to fibroblasts and infected the fibroblasts with Coxsackie virus B3, where you do see again an increase in AAC and interleukin-1 beta positive cells, which upon colchicine treatment, here again, this number of cells were reduced and associated with a lower production of collagen. So that we here concluded that colchicine prevents disease progression in viromyocarditis via modulating the NLRP3 inflammasome, not only in the cardiomyocytes as well in the fibroblast, and also involving the cardiosplenic axis. So all now examples that the NLRP3 inflammasome is active in different kind of cells. As I mentioned, cardiomyocytes, fibroblast, myeloid cells. And there is also now evidence that the activity can also be condition specific. So I showed you in acute myocarditis that there you get an increase, particularly in leukocytes and cardiomyocytes, whereas but for myocardial infarction here, more a raise in the fibroblasts has been shown. And Olsen et al. Could that also further address that the inflammasome expression and activity is different with respect to coronary heart disease and dilated cardiomyopathy. I mentioned different kind of cells, but what now with respect to inflammation, one trigger, how do now different organs maybe react? And here, what did we do here? We stimulated fibroblasts from the left ventricle and from the skeletal muscle with interleukin-6. And then you can appreciate that finally, with respect to myofibroblast marker alpha smooth muscle actin, or with respect to the NLRP3 inflammasome, that here you do see similar effects on the fibroblast, be it if they are now from the left ventricle or from the skeletal muscle. Though, if you look now to the chemokines and the pro-inflammatory CCL7, CCL2, then you can see that particularly the skeletal muscle derived fibroblasts lead to an increase of those chemokines, and here then further also reflected in a higher Lysx-C high to Lysx-C low ratio. Talking about migration and talking about Lysx-C high monocytes, here you also need to know that CD20 B cells also are important drivers of stimulating the migration of Lysx-C high cells, and this could now be shown now in a first safety study where they use an anti-CD20 antibody rituximab, and they tested that in patients with STEMI, and that here you can already appreciate that the treatment led to a reduction of levels of troponin 1 and TPRO-BNP, as well as of inflammation markers, high sensitive CRP and interleukin-6. All now examples of finally migration of immune cells, of monocytes, but what with respect to resolution of inflammation. And here now also following a myocardial infarction. And when here the animals were treated with VEGF-C, so to promote the lymph-angiogenesis, you can indeed see an increase of vessel area as well as vessel junctions, and associated with that, a drop in leukocytes and myeloid cells. Here you need now to know, intriguingly, that macrophages, that they are an important source of VEGF-C, and that they are producing VEGF-C upon efferocytosis. And that VEGF-C production in macrophages is so of importance. You can appreciate that if you here have a specific knockdown, that goes along with a lower ejection fraction, as well as also with lower lymph angiogenesis. And if we now look to the immune cells, you get also higher neutrophils, Lysx-C high monocytes, CD11b, and macrophages. Now, in this process of efferocytosis, there you also need to involve the metabolism. And here, this is particularly driven by fatty acid oxidation. That could be shown by here stimulating the cells with apoptotic cells, and where you can appreciate an increase of the oxidative capacity reserve and reduced when now an inhibitor for fatty acid oxidation, etoxamoxir, was used. And along with that, that if you stimulate so the cells with apoptotic cells, you get an increase of interleukin 10, so indicative for polarization to M2 macrophages, and again blunted when you use the fatty acid oxidation inhibitor. Now, talking about polarization, this does not only occur in macrophages, this also occurs in T cells. And here, with respect to metabolism, glycolysis is particularly related to Th17 cells, whereas by T regulatory cells, they depend on fatty acid oxidation. And here, in an experimental model of dilated cardiomyopathy, you can appreciate that this model goes along with increased Th17 cells, and in parallel with lower T regulatory cells, and reprogramming in the direction of glycolysis. Now, if they use a glycolysis inhibitor, and here shown now in the middle, so in 2-deoxyglucose inhibitor, then you have lower presence of IL-17 expressing cells and an increase of FOXP3 positive cells. That could then be further confirmed, the relevance of glycolysis in dilated cardiomyopathy, and that could be shown by performing an adaptive transfer of CD4 T cells from the dilated cardiomyopathy mice in new mice. And then you can appreciate on the right that you have an impairment in the ejection fraction and higher dilation, and going along with a higher cardiac fibrosis. And this now in contrast when you perform an adaptive transfer with CD4 T cells, which are from DCM mice but treated with the glycolysis inhibitor, then you get an improvement in ejection fraction and less dilation and lower cardiac fibrosis. I talked now a lot about metabolism, and which drives me to go to the gut, where here the intraepithelial T cells play an essential role in guiding metabolism, and here with respect to the bioavailability of GLP-1, of glucagon-like peptide 1, where the presence of the T cells lead to a lower bioavailability and of GLP-1 and associated them with lower metabolic function, higher obesity and diabetes, and also risk for atherosclerosis. And that could then also be shown in beta-7 knockout mice, so because there's intraepithelial T cells express the integrin beta-7, and then you can appreciate that those mice have lower plaque size and also lower presence of leukocytes in the plaque. Now, before I mentioned examples, particularly of heart failure with reduced ejection fraction, where the initial trigger of inflammation lied within the heart, be it myocardial infarction, but also myocarditis. And now I jump to heart failure with preserved ejection fraction, of which you know that according to the paradigm here, low-grade inflammation induced by comorbidities is the main driver of HFpEF pathogenesis. And one of the comorbidities, let us focus now on obesity. There indeed it is shown, or it is known, that visceral adipose tissue is an important source of inflammatory cytokines. So here TNF-alpha, interleukin-1 beta, also alarmins, S100A8A9, and then finally the release here of S100A8A9 leading to activation of the NLP3 inflammasome, And further on, interleukin-1 beta stimulates and again the production of new monocytes neutrophils, which then on their turn can migrate into adipose tissue, so further provoking adipose tissue inflammation, but on the other hand, also not ruling out that those cells can also migrate to the heart. Talking about fat in the context of HFpEF, we may not forget epicardial fat. And here also besides the fact as being an important source of pro-inflammatory cytokines, also not forgetting the direct effect of compression on the heart. And talking about compression, that brings me to mechanical stress. And first of all, I showed you now all examples of how inflammation leads to fibroblast activation and how then the fibroblasts in turn can further stimulate the inflammatory cells. But in addition, so also mechanical stress can provoke the fibroblast activation, and not only fibroblast activation, but also the inflammatory cells. And that mechanical stress is so of relevance. I show you here via an example where they performed a mechanical and left ventricle unloading. So here this is a patient with a fulminant myocarditis with a cardiogenic shock who needs a mechanical circulatory support, and this by means of this axillary pump, which you see here. And due to the left ventricle unloading, you got, and these are data from endomyocardial biopsies, you can appreciate that you get a downregulation of integrins as well as a modulation of the extracellular matrix, and that beyond that, with respect to inflammation, we see also a lower expression of members of the innate immunity, so S1A8, A9, NLP3, and also a lower immune cell presence. And when we talk about inflammation, we also may not forget that finally our guideline-directed heart failure drugs, that they do have also immunomodulating effects, which is maybe not so strange knowing the really strong interrelationship between heart failure and inflammation, but also to take into account. And that brings me already to my last slide, and here particularly also maybe as a bridge to the subsequent speakers of the webinar here, we will probably go much more into detail into immuno-cardiology, where the oncology field finally had a main impact on immunomodulatory therapies in heart failure in the sense of introducing also techniques like single-cell nuclear sequencing, also the importance of checkpoints in immune cell activation, and potential therapies like CAR T-cells. With that, I would like already to conclude that inflammation is diverse and complex. And if we want to come to patient-tailored treatments, that for that we need an in-depth characterization. And we learned already from the past that one size does not fit all, and that patient-specific treatments are needed, which was also supported by the CANTOS trial. And there are for the future also further potential targets, be it on migration, clearance, mechanical stress activation, and so on. And here also further being, as mentioned, driven more by the cancer field, where we learn from how important stratification is, as well as inspiration for techniques and therapies. And with that, I'd like to thank you for your attention.
Thank you very much, Sophie. That was a very comprehensive and very great talk. Thank you very much. I forgot to mention earlier, but if anyone have a question in the audience, you can drop it on the Q&A directly, and then we take it from there.
Did you all force quit application during the presentation, or was it only me?
I didn't. What you said?
while presenting, did you always see on my screen came forced quick application? Oh, you also saw that. Okay, I'm sorry for that. I thought my computer would crash while presenting.
Yeah.
Okay.
We'll quickly take a couple of questions, just a couple, and maybe someone in the panel. Do you have any questions, Marinos or Gustavo? I mean, I can start with the one that may be silly. I was fascinated by the connections of the inflammation from the adipocyte to the heart failure. Maybe I miss it because I'm more working on the heart failure with preserved ejection fractions. If you can clarify a little bit, how does that affect, what drive the migrations of those inflammatory cell cytokine toward the heart during the heart failure with preserved ejection fractions?
So, first of all, it is important that adipose tissue is an important source of inflammation. And there are now also new data with respect to interleukin-6, because if we talk about adipose tissue is not equal to adipose tissue, that we also need to take into consideration. This particularly the bad fat, the visceral adipose tissue, where a lot of cytokines are produced. And for example, women, which are much prone for HFpEF, they mainly see a larger increase in their visceral adipose tissue compared to men. They also have an increase, but not at that extent. And with respect now to interleukin-6, that also has been shown that the more the fat, and also depending on the region, that then you have higher interleukin-6 levels, and the more interleukin-6 levels, that also leads to exercise intolerance. If that answers your question.
Yes, yes. I think we have some question in the chat. I'll quickly read that. Okay. First, we get a question from Gustavo.
So basically, my conclusion slide is pretty much in line with what Sophie presented in terms of stratification of patients and so on. But perhaps I'd like to ask your opinion on what do you think could be now in terms of future, how can we stratify patients in terms of immunological burden? Because it's clearly, as you presented, right, in the 90s, we had this idea of TNF goes up, inflammation might be bad, so we go with anti-TNF, and one size fits all is not the suitable approach, even though inflammation clearly is important. But now we come to the point we need to understand an individualized base, like the CANTOS trial did. But could you perhaps comment a bit on what are the avenues that you see in terms of phenotyping patients?
Yeah, so I think because inflammation is so context dependent and time dependent, I think it's first of all good to have a biomarker driven therapy, so that you know really what you're treating and how long you finally should treat. That depends on, again, of the underlying etiology, and in the easy way is, of course, if you would have biomarkers in plasma, which are easier then to detect, but for specific disorders, as now for myocarditis, where so far the belief is that one needs to have the endomyocardial biopsy to know which kind of immune cells are there. The characterization, and also a more profound characterization as now in the normal diagnosis, would there be of importance. If we talk about myocarditis, this is now CD68 and T cells are analyzed, but we get also more and more insights that, of course, T cells, I don't need to tell you, are not equal to T cells. So that for that point of view, also we found it in post-COVID patients, they have more CD8 compared to CD4 cells, for example, so that there, depending on the presence of the immune cells, we can then come to more tailored therapies, like here, CD8 therapies, antibodies, but thinking also of patients which were refractory, for example, to methylprednisolone and azathioprine. Finally, they had an increased CD20 cells in their endomyocardial biopsies, and they responded then to rituximab. So that's the strategy I see. Well, characterization depending on the etiology, if you can do it via plasma markers, cytokines, or also specific immune cell subpopulations, where now the field of single cell sequencing, of course, gives us a lot of information. Not saying that that will land in our diagnosis, but the single cell techniques lead finally to the identification of cells, which then might be evaluated via flow cytometry and then used for being targeted.
Thank you.
Marinos?
I had a question actually, but about the link between lipid inflammation and postpartum myocarditis and so on. But actually, there are 3 questions in the panel, which I think we should prioritize for the sake of interactivity, and maybe we can actually all comment on them. So why don't we go ahead first with the comments, and then I'll come back to my question.
Okay, that's good. That's a good idea. Okay, so the first question is from Juma. Juma, hi. I think from the UK. Which part of myocardial inflammation should we be targeting? The CANTOS, CANTOS trial focus on the laser stage, which clearly showed to not be effective and limited to healing.
So as mentioned, now to say this kind of cytokine is the winning, that I will not say. I will rather speak for be it immunomodulatory strategies, or be it, as mentioned, be it an anti-cytokine treatment, but then not per se for the specific long duration. So that should be biomarker driven, and then one can know what, and also as I showed with the CANTOS, one way of that the fact that the all-cause mortality was not changed was due to the increase of fatal infection. We may not forget, you finally get a long-term immunosuppression. But on the other hand, we had also lower cancer development. So here we need, again, because we really affect, and inflammation is involved in many mechanisms, we need to have this controlled and biomarker driven, and rather, if possible, modulating as solely with one specific cytokine to block.
Yes, I'm not sure we're going to go through all the questions. Probably Sophie could answer to them on the chat, on the Q&A answer directly, because I think it's we should move to the next talk, and we could come back to that later on if you have more time, since they're still on the Q&A box. So we move to the next speaker, and that would be Associate Professor Gustavo Ramos from Würzburg. He's leading the lab in Immuno-Cardiology in the Comprehensive Heart Failure Center in Würzburg. And he'll be talking about the role of heart-specific immune response in myocardial diseases.
Thank you very much for this kind invitation. I guess you're all, can you hear me? Can you see the presentation? Can you all hear me?
Yes.
Thank you. So thank you for this kind invitation. It's a pleasure to be here and share the session with the colleagues, Sophie and Marinos. I'm gonna focus a bit more on T cells and heart-specific immune responses in the context of myocardial infarction. But perhaps I would like to start with 2 quick announcements. First, if you're interested in cardiomyology, you may consider registering and attending the second cardiomyology meeting. Is going to take place in June 26th to 28th. It's near Würzburg, this wonderful location. It's a monastery in the Bavarian. It's a beautiful landscape, and many international world leaders in the field will be there. It's the second meeting following on the one a tradition started in Zurich 2 years ago. Super recommended. And also together with Daniela Chihakova, Sumant Prabhu, and Christoph Mark, we're editing a circulation research review compendium on cardiomyology. It's gonna be published, I think, in 2 weeks with 10 reviews on different aspects of cardiomyology. So if you're interested in the topic, I think these are two points to keep an eye on. So the heart has been rediscovered through the lenses of immunology. In the past couple of years, you have learned how to see, how to study immune cells, where before we could only see contractile tissue, we now see resident immune cells. So all these green spots you see here are tissue resident leukocytes, CD45 positive, mostly cardiac resident macrophages. That's a completely intact, healthy murine heart. And also with this micrograph here is a three-dimensional reconstruction of an infarcted mouse heart, day 5 post-MI. And all the yellow patches that you see here are infiltrating immune cells. And the sheer amount of immune cells you see in the heart, at least to me, it tells that if you want to understand the pathophysiology of tissue repair and ischemic heart failure, we really need to delve into immunological mechanism. We study post-infarction repair in 3 main waves in a nutshell. This is a figure adapted from this nice review from Elvira Forte and Nadia Rosenthal. So after myocardial injury, there's an initial phase called inflammatory stage, where this massive influx of phagocytic cells that are important to clear up the cell debris, and then it gives way to the proliferative phase, where you have new extracellular matrix being produced, angiogenesis, and it eventually goes into maturation phase, where the heart changes the shape and geometry, and you can get wall thinning and remodeling. So this is a plot from the group of Clément Couchon, and they basically purify all immune cells from an infarcted mouse heart, and they do single cell transcriptomics. And I think this image here really gives a good overview on the cell population that you find in an infarcted heart. The exact numbers and distribution will change depending on the day post-MI, but you clearly see that the vast majority of cells that you find in the heart post-MI are monocytic cells, monocyte macrophages, and there's a reason for that these cells, they are phagocytic cells. They can clear up the cell debris, and all this necrotic cell debris, they can be cleared by them. There are very few T cells there. You can also find B cells and neutrophils, and yet these are the cells that my lab is mostly interested into, the T cells. And I would like to draw some words on why T cells and why those numbers. And the first thing is, after infarction, you clearly have this necrotic cell debris that needs to be removed. And inflammation is not necessarily bad. And actually, inflammation is a step, it's a path to healing. Without inflammation, there's no repair. There's this former paper from 1978, also from the group of Eugene Braunwald. I think Sophie showed another one from the group. But basically, if they treat infarcted rats with high dose corticosteroids, it basically you completely block inflammatory response, and there's no repair going on. So they speak of a mummification of the heart. So without inflammation, there's no repair. That's the first take-home message I would like to stress here. But of course, inflammatory response in a tissue that cannot regenerate, where myocytes don't proliferate, it's a very dangerous thing, right? So if myocytes, if macrophages, monocytes, neutrophils, they kill more myocytes, it can be a tragedy. So it's really about the balance between this pro-healing activity of inflammation with the collateral damage they can produce. And I think most of the groups in the field, they're trying to understand this complex cell-cell interaction amongst different cell types and the different subsets, different flavors of T cells, macrophages, neutrophils, and so on, to understand whether there are some pathways that we can push to get a better repair, fibrotic repair, or some pathways that you can inhibit to avoid excessive damage. So as I said, my team is mostly interested in T cells, and this is an autopsy material from an infarcted heart, and that gives you a feeling from how many T cells you get there. So they're not the most abundant cells. And the second thing I'd like to stress in this slide is that the immune system is really not about cell competition, which cell is outnumbers the other, which cell is cooler, or so on. It's really about the cell-cell interaction, and that the cells, they do different things depending on this interaction. So, and T helper cells, the CD4 positive T cells, they get this name helper for a reason. So they don't produce antibodies, but without T cells, without T cell help, B cells will have a hard time producing high affinity antibodies. T cells don't phagocyte the necrotic cell debris, but with the cytokines they produce, macrophages will do it much better. So that's what we're interested in the lab, is really to understand this T cell to myeloid cell crosstalk. And the second thing I'd like to stress is that why T cells are not so outnumbering macrophages in the tissues, that T cells get activated in the lymph nodes that drain the heart. And for cardiac injury, this is going to be the mediastinal lymph nodes. They're behind the thymus in different places. We consistently find them enlarged with proliferating cells in pretty much every experimental model we have looked at so far. And this is a collaboration with the nuclear medicine department here in Würzburg, where they have used a radioactive CXCR4 tracer. It's a chemokine receptor expressed in many immune cell types that you can really check by PET CT scanning and the lymph node morphology and cellularity. And as you can appreciate here, after myocardial infarction in patients, those mediastinal lymph nodes that drain the heart, they're enlarged and with increased cellularity. And this is a hallmark of adaptive immune responses, as we call it. So the conceptual framework that we came up with, it's depicted here. So we think that whenever there's a myocardial injury, there's going to be a local inflammatory response, mostly driven by phagocytic cells, monocyte macrophages. But all this necrotic cell debris, this dying myocytes, chunks of cells and proteins, they are drained to the lymph nodes via lymphatics and also via migratory DCs and Reg cells. And there they can give rise to antigen-specific immune responses. So B cells may produce antibodies targeting cardiac antigens, and T cells specific to cardiac antigens might eventually migrate to the heart and impact what is going on there. And we're interested in a second layer of adaptive immune response and trying to understand how this balance between the healing activity of inflammation and the collateral damage it can produce, how that plays out in the context of myocardial infarction. Today, we'll only focus on T-cell studies. If you're interested on B cells and antibodies, you can come to the ISHR meeting in Toulouse. Johanna Siegel from the lab, she'll be there giving a wonderful talk on antibodies. So when we look into this figure here, the main question we've been asking ourselves are, okay, what are the antigens, the cardiac proteins that trigger specific immune responses, and how those specific B and T cells can impact the heart? So when I start with that, we have first to address, okay, what are the antigens, right? So if you think about the heart, we have learned from the work from Nadia Rosenthal's group, Alexander Pinto, Mona Litvinokova, so that the cellular composition of the heart is far more complex than we used to appreciate. Myocytes, they make roughly 50% of the cells, they're a bunch of other cell types. So when you think about the volume of cell mass in the heart, is really predominantly cardiomyocytes. And within the myocytes, most of the cell volume is really myofibrils, so contractile elements and mitochondria needed for this activity. So when you think about the heart-specific protein makeup or transcriptome, this is data from the Human Protein Atlas, we're basically talking about contractile proteins and mitochondrial genes or proteins. So this is data from the Protein Atlas, and this is basically show how the cardiac transcriptome overlaps with other tissues. And this little bubble here, it shows that there are only 36 proteins that you can regard as heart-specific. So it's really not that many. And we thought, okay, this could be a good start when you want to think about heart-specific antigens. So we made peptide libraries covering some of those proteins, which is basically the cardiac actin, myosin-binding protein, C3, myosin-heavy light chains, troponins. And we synthesized more than 200 peptides, and we got cells from either infarcted mice or sham-operated mice, and we re-stimulate the cells with those cardiac peptides. The rationale being, if the cells were expanded in vivo to those antigens, you can recall those responses ex vivo. And after doing that, testing for over 200 peptides in biopsy mice, you got a hit, and only one hit for a protein from myosin heavy chain. And that's the exact peptide position that fragment. It's a 15-mer in that position. And that's exactly the same peptide that people from the autoimmune myocarditis field have been working with since the 90s. This tradition work from many groups. So once we know the antigen, and we can now start modeling that, the T-cell responses that are specific to myosin. And we built up this toolkit through a collaboration with Professor Burkhard Ludwig from St. Gallen. He has generated a mouse model with the transgenic T-cell receptor in which all CD4 T-cells are specific to this myosin antigen. And he was kind enough to share this with us. And so we get this myosin-specific cells that we call TCR-M, so T-cell receptor specific for myosin. We label the cells, we transfer them into an infarcted mouse, and we track what do they go, what do they do. And this is, again, a three-dimensional reconstruction of an infarcted mouse heart. The lack of autofluorescence shows the infarcted region, and if you zoom in here, you find myosin-specific cells there. So it's evidence that the infarcted myocardium is recruiting myosin-specific T cells. And if you have a model, you can really track what these cells do, how they differentiate in the heart, how they impact the tissue. And for us, the most impressive thing was that the myosin-specific cells that we recover from the heart, they express the transcription factor FOXP3, which it really pushes T cell for regulatory immunosuppressive phenotype. Before we transfer them, they're not FOXP3 positive. The cells that we find outside the heart and not FOXP3 positive is something that seems to be going on in the heart specifically. And of course, if you find the cells, we can characterize them through flow cytometry whatsoever, but you can also do single cell transcriptomics. We do it not because it's fancy, but because, you know, I think it's really meaningful in this case because they're really, you find few of those antigen-specific T cells, and if you want to subset them by flow cytometry, at some point you really hit the wall, it gets reach the limit. So by doing single cell transcriptomics, you really get transcriptomic per myosin-specific cell, and you can analyze how to differentiate. So here you can really tell apart the cells that we call endogenous. These are the CD4 cells that were there in the recipient mice, and these are the myosin-specific cells that we transfer. You can easily discriminate them. And I will not overload you with lots of UU maps or violin plots, but just to show you that if you interrogate transcripts that you typically see in regulatory T cells, they are really enriched in the endogenous Tregs and in the myosin-specific T cells. They really look like Treg cells, not just at flow cytometry level, but also at the single cell seq level. But of course, we started interrogating how the cells impact the post-MI, the tissue repair. So we have groups of mice that we either infarct them but didn't transfer cells, or cells that we transfer myosin-specific Tregs. And this is day 5 post-MI analysis on just the scar tissue, and you see there's far less monocyte macrophage infiltration in the presence of myosin-specific Tregs, even though there's a very few cells, right? So, but they're very powerful immunosuppressive, and they can really blunt macrophage recruitment, monocyte recruitment. If you get the myocardial scar and run bulk RNA-seq analysis, you can really see that in the presence of Tregs, you downregulate expression of various innate immune transcripts. And the picture here is very clear. If you plot various chemokines, cytokines, it's really upregulated in the presence of myosin-specific Tregs, except for CXCL12. And I've learned afterwards that actually this chemokine is really important for angiogenesis process. So in the end, it also makes sense. And the presence of Tregs blunt the expression of pro-inflammatory cytokines, chemokines, but it also upregulates expression of collagens, which are important for tissue repair. So we think that those Tregs are really bringing about the resolution of inflammation, pushing for tissue repair. So the conclusions I would like to, partial conclusion at this point here, I'd just like to stress that infarction triggers heart-specific immune responses, in this case, CD4 positive T-cell responses. And what was really impressive for me is that the myocardial milieu is pushing the myosin-specific T cells to acquire a Treg phenotype once they reach the heart. We don't fully understand that yet, but it really wrapped our heads around that, because I started in the field asking what T cells do to the heart, and I realized now that it's really, you should be asking how the heart talks to T cells, because it's really pushing them for a very specific protective phenotype. I'll change lanes a bit here, and I would like to bring about this problem of aging, because we all do our experimental models on young, healthy mice. The LED ligation model, it's really a good model. However, we need to bear in mind that the patients that develop myocardial diseases, they're mostly elderly patients with several comorbidities, right? Diabetes, hypertension, and so on. And the immune system is pretty much different in the elderly population. I think the COVID-19 pandemic made it very clear to us. So if you really want to have translational to push translatability of our research, we should start doing more research on aged animals and bring more the comorbidity factors that might influence inflammation and so on. But of course, it's very expensive to work with 2-year-old mice, but we have been doing that as well. But also, I would like to bring your attention to the opposite side of the spectrum, which is 1-day-old mice, that because adult mammals cannot regenerate the heart, but 1-day-old mice can. And if you want to learn about the best case scenario, we should really be studying 1-day-old mice. And I would like to briefly touch base on that story. It was a collaboration we had with Bernhard Hauptner, now in Zurich. So he's been doing LED ligation in 1-day-old mice, which I find it amazing. And basically what they show is that if you perform an infarction in 1-day-old mice, they can completely recover, full regeneration. But if you do that when mice are 7 days old, you get a typical fibrotic scar, and as you see in adults. And it seems that is also true for humans. So Bernhard also published a case report. There was a human newborn child that developed myocardial infarction due to complications, a thrombus formation, and you can really see that this 1-day-old boy, that there's really a kinetic area in the heart, and you get troponin going up, CK going up, and they just went on with the standard treatment for myocardial infarction, thrombolytics, and so on, and there was a full recovery of cardiac function. And to the best we can tell, there's a full recovery. So it might be the case that 1-day-old mice, it has been shown also pigs and possibly in patient that there's a time window where you can have full recovery. Definitely not in adults, right? And when I met Bernhard and I saw him presenting this data, I told him, Bernhard, there is, at least in mice, this perinatal thymic failure. And when the mice are born, there's basically very few T cells around. And this is data from our lab. So the CD4 T cells number and CD8 T cells in the spleen of 1-day-old mouse, it's basically they're absent, and they catch up during the first week. And that's basically when regeneration disappears. So we started thinking, could that be any relation? Of course, association is not causation. So we came up with this experiment. We said, okay, what happens if you get a spleen from an adult mouse and you purify the T cells and you transfer them into a 1-day-old mouse, and now you will infarct them? They have the neonatal heart with proliferating myocytes, regenerative capacity, but they have an adult-like immune system. And this was a really fun experience to do. It was really fun collaboration. And this is ejection fraction data that Bernhard has. He can do that on 1-day-old mouse. And this lines above here, this is the sham operated, but here that's what matters. So this pink line is really, this magenta line is 1-day-old mouse. So that they really get ejection fraction goes down day 1 post-MI because there's an infarction, but they have a full cardiac recovery, right? But 1-day-old mice that are infarcted and they receive adult T cells, they get stuck with a poor cardiac function. So they don't regenerate anymore. If you look histologically, this is the amount of inflammation, so to say, monocyte macrophage infiltration in a neonatal mouse. When you compare with a neonatal mouse that received T cell transfer, you see there's much more inflammation going on. And also there's more fibrosis in the presence of adult T cell. So it's not the transmural cardiac remodeling, transmural fibrosis and so on, but you do get some more collagen deposition in neonatal mice. When I first saw this, it was a bit underwhelming, but when I talked to people studying neonatal tissue repair model, they say it's almost impossible to get fibrotic repair in neonates. So this was actually quite something they were telling me. And in this study, we really approach on the mechanistics of that. We think when T cells come in, they produce interferon gamma and other cytokines that will push for myelopoiesis in the bone marrow and lead to more monocyte recruitment, but you can read the publication. What I want to say is that, so we published it 2 years ago, and we think that when T cells come to play, when there's tissue repair, they will push for a quick fibrosis. And just this year, there's this also super interesting paper from the group of Eric Olson, and they also show that this PD-1, PD-L1, so immune suppressant signaling, it's important to keep the heart protected from a T-cell response that's crucial to allow cardiac regeneration in neonates. So we think that this immune activity really brings about this dichotomy. So when the T-cells come into play, they push for fast fibrosis, and depending on how the immune cell reacts, it can go for regeneration. And I think this is not bad or good per se. It's important to make it clear. I think if you're an adult mammal and you cannot regenerate, you want to have a quick fibrosis to avoid cardiac rupture. But if you're a one-day-old mouse and you can regenerate, you probably want to get rid of the T cells, and the hearts do it by getting full of PD-L1. And each time I present this data, I get the question, so that means if you don't have T cells when you're an adult, you regenerate, and obviously not. We actually infarcted rag knockout mice that don't have T and B cells, and they'd still go for fibrotic repair at adulthood. So because regeneration really depends on many factors, right? You have myocyte proliferation capacity, the myocyte metabolic status, the hemodynamics. There's a bunch of stuff that need to come together to allow regeneration, and it's not just having or not having a T cell. However, when you do have adult T cells producing high levels of interferon gamma and making lots of inflammation, it definitely blocks a regenerative potential. So now I'm coming close to my talk. I'd like to briefly draw some words on the translatability of those results, and what about humans? Do you find antigens in patients? So of course that's much harder, because T cells, they will see antigens, protein fragments that are presented on the major histocompatibility complex. In humans, the human leukocyte antigen, HLA, which happens to be the most polymorphic loci we have. So meaning each one in this room will have a different HLA makeup that might be presenting slightly different peptides. So it's really hard to find antigens in humans. But Niels and Marga in the lab, they were brave enough to try it. We built up a cohort of 50 patients with myocardial infarction or coronary angiography as control, with no heart disease, no ischemic heart disease. And they tested again against a bunch of different, different antigens, and they got a hit for adrenergic beta-1 receptor, and we found one peptide specifically. And to make that clear, 80% of the patients don't respond to that antigen, but if you see here, but 20% of the patients do respond. And it might sound underwhelming if you're not a human immunologist, but it's really down to this HLA diversity. And when it did the HLA genotyping of these patients, all the patients able to respond to an antigen coming from the adrenergic beta-1 receptor, they all have the same HLA. So we think that for a combination that it's found in 20% of the population, Caucasian population, you get this HLA specific that might be presenting the specific antigen. And that's my last slide, if I'm not running out of time. Of course, besides looking for antigens and having model antigens in patient, you can also look for the T-cell receptor. So here I would like to mention the T-cell, they will interact with antigens through this T-cell receptor that are formed through somatic recombination process. The T cells, they will have different gene segments in the TCR alpha and beta loci, and they will just shuffle that and recombine. And that's how we get this huge diversity. That's why you can basically react to anything that exists in nature. So one idea is that you can access this T cell receptor diversity in patients. So what we did is we retrospectively analyzed one cohort from Würzburg. We stratified the patients based on cardiac MRI data into what we call good healers or poor healers, meaning patients that started similarly, but the good healer patients, they recover cardiac function 12 months later above a predetermined threshold, call them good healers, and the poor healers, they get stuck with a poor cardiac function. So, and we compared the T cell receptor repertoire in the blood of those patients by doing bulk RNA-seq of the T cell receptors. And this is work done with the group of Incarnita in Paris. And after doing some statistical modeling, which they do excellently, so they identified a signature of 348 unique T-cell receptors that can discriminate between good and bad healers. So then the way you can read this graph is each line is the patient and the condition here, and each column is a specific T-cell receptor. And you can see here, this is a T-cell receptor alpha and beta. You can really tell apart good healers versus poor healers. And what was really interesting is that was the presence of some T cells, not the absence, that defined the good healers. We cannot tell if they are Treg cells, but based on our research data in mouse, we tend to speculate that at least. But I think this is at least data that you can associate cardiac MRI, gold standard measurements, follow-up measurements, longitudinal assessments with T cell receptor repertoire data. And with this, I'd like to wrap up saying it's, I think, prime time for cardioimmunology. I think it's now beyond question that inflammation is important in various cardiovascular diseases. And also, there have been many conceptual and methodological advances in the field. I think if you would study that 20 years ago, basically you only could do some histology analysis or measure CRP analysis. And right now we're doing multi-parameter flow cytometry, single cell transcriptomics, spatial transcriptomics. You can really get a lot of data to subset those cells, get a lot of granularity. And also in the clinics, we're moving way beyond CRP. We got people like Corey Levine and Florian Leuschner, this ImmuneFib, Leduc. They are developing their own PET tracers to measure cardiac macrophages non-invasively in patients or fibroblasts. There's a lot going on. And I think the future, as Sophie already mentioned, the idea is really to go from this picture from unstratified patients and use immunological-based diagnostic tools, be it imaging, PET imaging, single-cell sequencing, flow cytometry, or biomarkers to really tell apart patients based on the inflammatory burden, and they will be treated differently. That's how I foresee the future developments in the field. I would like to finish by thanking the team. It's done this wonderful work, especially Murillo, Dia, and all the others working on T cells, also Max Rickman. And if you want to learn about B cells, you can come to the ISHR and listen to Johanna and also all the funding agencies. And I'm happy to take questions.
Yeah, thank you very much, Gustavo. That was an amazing talk. And I also like what you said at the end and in relation to what Sophie said, and put it in the future, because that was one of the reasons we wanted to have this, so that the ECI, MCI could have an idea of what's going on those fields. I think we move directly to the next talk with Marinos. In the meantime, you can write your question in the Q&A box, and then we take it in the end when we have if you have some more time left. At the same time, Sophie of you can also directly reply in the Q&A box, since everybody can see. So we move directly to Marinos Kallikourdis, who is leading the lab in adaptive immunity in experimental medicine and pathology. You can just go ahead. I think that's
okay. Excellent. So thank you very much for the invitation. This is a great session and a great place to be. So I'm going to talk to you about T cells in non-ischemic myocardial diseases. So I guess complementary to what Gustavo has been saying. I was told that this is quite a sort of cardiological as opposed to a cardioimmunological audience. So I thought of doing just a slight zoom out to put people into context. Most of us, when we think about the immune system, we think of it as the way through which an organism ourself defends itself from the pathogens. But actually, if you go back to the sort of grandfather of immunology, which is Ilya Mechnikov, he thought of the immune system as a system that regulates physiology, pathology, and development. And the point is that clearly defending ourselves from the pathology that can be brought about by pathogens is a way of dealing with pathology, and adaptive immunity specifically, which is one of the things my lab is interested. The main thing my lab is interested in evolved in vertebrates, but I would argue that the next step in the evolution of adaptive immunity, which is actually the addition of very suppressive anti-inflammatory cells, the regulatory T cells, showed up enabling placental pregnancy because on top of, say, survival, because you defend yourself against pathogens, you need to also reproduce. And these two are key evolutionary drivers. Just a little point to clarify what I mean by enabling placental pregnancy. Most of these animals that you see here reproduce through eggs. We don't lay eggs. We're sort of placental mammals. The benefit with that is that you can give a lot more food to the fetus. The fetus can grow a bigger brain, take over the planet. But the problem with it is that in the absence of an egg, the maternal adaptive immune system recognizes the paternal antigens present in the fetus, and it would reject them. It doesn't do so because there is this population of regulatory T cells, which are immunosuppressive, which about 20 years ago we showed are essential if you want to reproduce with someone who's not your twin. And the point is, and this is really, really kind of intriguing, is that the full set of domains of the gene that makes these cells immunosuppressive, called FOXP3, shows up in the platypus. So just before the egg is lost and placental pregnancy happens. So that could mean that the evolutionary drivers are for adaptive immunity are defense from pathogens and reproduction through a placenta, which then enables the speculation, and for now this is a speculation, that once you go past the reproductively active age of the females, you don't have any evolutionary optimization for what adaptive immunity does. So T cells, B cells, Treg cells may do things which are not ideal. There's a word for that. It's called antagonistic pleiotropy. It just means that you go past the range through which evolution has sort of fine-tuned what the cells do, and they do things which are wrong. They're maladapted. And of course, in diseases that have an incidence mostly in mid and late life and have an inflammatory component, that means that these cells could be a contributor to these diseases. And first among these, in terms of the sort of clinical significance, is cardiovascular disease. So together with Gianluigi Contarelli, who heads the cardiovascular department here in Humanitas in Milan, we've been asking the questions in the last 10 years, do maladapted roles for T cells contribute to heart disease? And we started quite a while ago looking at biopsies from heart failure patients, different forms of heart failure, and we found that we could find T cells in the heart proportional to the extent of fibrosis, so proportional to the severity of disease. And you get the same result, pretty much whatever cardiac disease you look at. And then we switched to the pressure overload of the transaortic constriction model, which is one of the standard models for heart failure in mice. And we found that once you apply this pressure overload on the you look at the left ventricle and you see T cell infiltration, whether you look at it by FACS or immunohistochemistry. So you see T cells getting activated as a result of the fact that you're putting sort of stress on the heart. So what is happening here, and it sort of falls back to what Stephanie was saying before, Sophie was saying before, the heart is stressed and it releases cytokines, and these cytokines are no different from the cytokines you get when, say, you have a pathogen. So the immune system doesn't know that this is not a pathogen, and you get recruitment of innate and then adaptive immune cells. So at this point, we had the very simple idea, given that T cells tend to be the coordinators, the orchestrators of the immune response, which is mediated by the innate immune system afterwards, so the macrophages, neutrophils, and interacting with fibroblasts and so on. So we thought, why don't we just use something which is already in the clinic, which blocks T cells and is already safe and efficient? So we picked abatacept, or CTLA-4 Ig. It's a drug which is now generic, which blocks the co-stimulation of the T cells. So it blocks T cells from becoming completely activated, as they should. And this is being used in arthritis. We know it's a good drug. It's a safe drug. So to cut a long story short, we took mice with pressure overload, and you apply the pressure overload, they start losing systolic function. This is ultrasound for systolic function. And then you give the drug which blocks T cells from working, and you blunt any further loss of systolic function. It doesn't go back, because just like Gustavo was saying before, you cannot really do regeneration in adult mice. But it doesn't get any worse, and that's quite important. I mean, this difference is sort of 3 times what you would get if you gave beta blockers to the same mice. So this became a little paper, which we published, again, quite a while ago now, essentially showing 2 things. So on a more translational level, I guess it means that pressure overload heart failure in mice, at least, is a T-cell dependent process, because we can block it with a drug that is very well known, because its mechanism is fully understood, can be blocked through this drug. On a more sort of philosophical level, it suggests that T cells have not evolved to deal with stressed hearts, and therefore their role in the context of the heart is maladapted. I would argue that the blueprints of evolution, as I was saying before, are pathogens, pregnancy, and some more complex variations thereof, which is when you have pathogens during pregnancy and when you have useful microbiota in the gut. And so then we thought, what else can we apply this logic to? And if we go back to the slide I was saying before about the various diseases that can be linked to maladapted effects, evolutionary maladapted effects of T cells, I had listed age-related pathology, and obviously that would be a good candidate. And that's a very easy thing to model. You just take mice and you wait. And if you do that, you see that they start, just because of aging, they start losing systolic and then diastolic heart function. And I guess the key point here is that if you immunophenotype these hearts, if you look at the immune mediators present in these hearts, you see exactly the same wave of inflammation that follows, say, the aortic constriction in the pressure overload model. So you have a sequence, first innate, then adaptive immunity. The sequence is the same. The timing is not the same, which is very interesting and is something that should be sort of potentially analyzed quantitatively at some point. But this meant that we can try and block T cells. So we did that. We gave again the same drug once we could by ultrasound see that the heart dysfunction was kicking in. And so treating the mice with, again, sort of the same doses that you would use in human arthritis patients, we managed to block the further loss of heart function, both systolic and diastolic. And actually turned out, I mean, these are, I guess, mechanistic details, that this effect was IL-10 dependent. But again, this is a mechanism, this drug has been around for a while. We know how it works. It basically puts a brake. It's like a sort of regulatory T cells that come in a tube. And so again, the more sort of translational conclusion from this is that age-related heart failure, at least in mice, can be blocked by a drug that blocks T cell activation. Therefore, it is T cell dependent. And again, on a more sort of more conceptual level, the conclusion is that T cells have not evolved to deal with either stressed hearts or aging hearts. And this, which was work of Elisa Martin and Marco Cremonesi, came out about 4 years ago in Circulation Research. At this point, this is nice and right, but I mean, this, you could argue, is still mouse models, but this story got an amazing boost in terms of its sort of clinical relevance by the group of Javid Moslehi, who I'm sure many of you know, who describe, amongst others, very well that in patients, tumor patients that get tumor immunotherapy, which is meant to activate all T cells so that they can hopefully kill the tumor, 1 in 100 patients gets very severe myocarditis, which in 1 in 2 patients is lethal. And we were really, really thrilled to see that they adopted the same sort of strategy of using this arthritis drug, which blocks T cell co-stimulation in humans. And they have been doing so very successfully in an increasing number of patients. And I appreciate this is not exactly the same sort of cause of a cardiac disease, but it is the first sort of application in the clinic of a cardioimmunology technique to deal with something which is a cardiac phenotype. This actually got us quite curious about this phenomenon. These cardiac problems arising as a result of tumor immunotherapy. So we did a very simple experiment. We just took normal wild-type mice with no cardiovascular or oncological or immunological problems. Basically, if you give them anti-PD-1 at the standard sort of chemotherapy treatment, and you get the same result whether they have a tumor or not, actually, you end up with, if you look at their hearts 2 weeks later, you get the T cell infiltration, you get what we call a type 1 polarized inflammation, so there's a standard cytokines of a type 1 response, and you get a small but significant loss of cardiac function. And this is something that has been also confirmed by others, and it's something that we're looking at the moment in humans. This is interesting because this is not a 1 in 100 effect. All of them get it. So all of the mice get it, which means that maybe this effect is a bit more wide, if at the sort of subclinical level. Right at the same time, we performed one of the first single-cell sequencing analysis of the immune cells infiltrating the heart. Again, we use the pressure overload, the transverse aortic constriction mouse model, because that's what we have available here. So what we did is we induced the disease, and at 2 different time points, we isolated the immune cells from the heart, and we applied single cell sequencing on these. And what was really interesting there is that just about any immune cell you can think of, you can find in the heart. And if you look at the sequence of sort of rainbow colored different populations that you see here, you see that in late disease, all of the colors are sort of mixed around. The reason they're mixed around is because they're all responding in terms of the abundance in different ways. And actually, if you look at the genes expressed by these different populations, you see that all of these immune cells are responding to disease. And since then, this is, I guess now 4.5 years ago, people have shown that a lot of these changes are not just sort of consequences of the fact that there's inflammation. They really have an effect on the overall pathological outcome. Much like with the abatacept experiments, the stress is always there. The point is that if you interfere with the immune response, you can eliminate some of the pathological damage. The stress is still there. It's not going to kill you, though. A lot of stories came out of this analysis. I'm just going to focus on one because it's interesting, because it got mentioned in the previous in the previous talks. Amongst the populations we see in the heart, amongst the most sort of aggressively pro-inflammatory ones are macrophages, and there are 2 populations specifically which are the most pro-inflammatory amongst all the macrophage populations in the heart. And we found that they express a cytokine, which I'll admit I hadn't heard of until then, called oncostatin M, and we confirmed that you find that also the same in sort of human heart failure patient hearts. And on the flip side, you find its receptor on cardiomyocytes. What's interesting about this is, and this was mentioned in the first talk, about 15 years ago, people tried to use anti-TNF, which is one of the most successful cytokine blocking drugs used in autoimmunity. So it made a lot of sense to use it because it is one of the most successful autoimmunity drugs. And they used it, they did a trial using, or a couple of trials using it on heart failure patients, trying to see, okay, can we block inflammation to cure heart failure? And as I'm sure most of you know, it didn't work, right? And not only did it not work, it really put off a lot of people off the idea of using immunotherapy to try and treat cardiovascular disease. There was no way of knowing 15 years ago, but now we know, because there have been more recent work on autoimmunity, that if you are an autoimmunity patient and you take anti-TNF and your macrophages produce oncostatin, you are refractive to anti-TNF, which, as I said, is one of the most effective and successful drugs in autoimmunity, which means that given that there is a lot of oncostatin in the macrophages in the heart, the choice of anti-TNF was just really, really unlucky. And so, to go back to one of the questions in the Q&A that said, you know, are the conclusions from the CANTOS trial in a way telling us we shouldn't try late? Well, it really depends what mediator you use, and each mediator through immunophenotyping has to match the right point of the disease. So the take-home messages from this part are, I guess, that heart failure involves just about every immune cell subset you can think of, and this opens up a lot of potential new avenues for both study and, if we find causal relationships, also therapy. And as for the tumor part that I told you about, it also sort of suggests, and again, on a more philosophical level, the T-cells haven't evolved to deal with stressed hearts or tumors, and indeed you get myocarditis in tumor immunotherapy, and that's T-cell dependent, and you can block it with a drug that blocks T-cells. Some of the data I've shown you is on this paper by Elisa Martini et al. Came out in Circulation 4 or 5 years ago, which leads me to the last part of my talk. We're using abatacept, which is an autoimmunity drug. Does that mean that there are autoimmune-like mechanisms involved in cardiac disease? This is a question we've been working in the lab now for quite a while, and I just want to share with you the first part of that answer, or at least aspects of that answer, and it has to do with long COVID. So long COVID, which also affects the heart, as this beautiful paper by Valentina Puntman showed a couple of years ago, a lot of people who are sort of hospitalized for COVID-19 ended up having cardiac problems later on, even when the virus is sort of seemingly gone. And there's several different potential explanations for this. One is that there's direct damage in the heart by the virus, but there's also potential explanations involving immunity. Either there is a systemic innate inflammation, so cytokines that are generally causing damage, or that there is autoimmunity because of molecular mimicry. So there's antigens in SARS-CoV-2 that look like antigens of the heart and therefore lead to damage. Or there is another explanation, which I personally found very intriguing, which is called bystander loss of tolerance. So there the idea is that you have a T cell or a B cell that has reactivity to something that is expressed in the heart, and it gets co-stimulation, so the signal we're blocking with abatacept in other conditions, because a dendritic cell next to it got activated by a virus. So even if the dendritic cell is activated by a virus, it is presenting lots of antigens, including self-antigens. If you get unlucky, you might activate a self-reactive T cell or B cell. So to kind of investigate this, here in Milan, we had a lot of COVID patients in our hospital. So we screened them and we found some that had sort of suggestions of potential cardiac events during hospitalization, but they didn't have any previous cardiac pathology history. And we didn't split them into severe or not severe, because that is a split according to sort of, decisions made in a triage room, not according to tissue-specific information. But we did an MRI, cardiac MRI, 6 months after their hospitalization, and split them into people that had or didn't have cardiac dysfunction 6 months into post their hospitalization. All of them were COVID negative at that point. And the numbers were 50-50, which is the same numbers more or less as Puntman et al. Found. So then we applied multi-parameter FACS analysis on these and found that their B cells, the B cells on everyone who was sick, were more activated than the B cells in everyone who was not sick 6 months later. And then we ran an antigen pipeline, and we identified T-cell dependent autoantibodies against 2 autoantigens expressed in the heart that were shared by everyone who was sick and absent in everyone who was healthy. And up to this point, this is not entirely novel, because there's a lot of groups that have shown that you get autoantibodies in acute COVID and in long COVID. The difference is we synthesized these antigens and we sort of immunized mice, and the immunized mice had a loss of systolic heart function. And to give you more cardiological detail, they ended up having a dilated phenotype with eccentric hypertrophy. Unsurprisingly, because we immunized with these antigens, we had T cells infiltrating the heart, and we had specific antibodies to these antigens. So there's 2 conclusions here, and they're interesting. So the first conclusion is that there's a shared autoimmune antibody response against the heart in the patients with a cardiac sequelae, which on its own is sufficient to generate cardiac problems. So it's demonstrably cardiotoxic. So in a way, it sort of moves the barrier of proof 1 step forward in terms of showing that there is an autoimmune aspect to long COVID. And the second point is that these antigens, neither of them had any sequence similarity with SARS-CoV-2. So there cannot be, at least in this cohort, any cross-reactivity with the virus. It cannot be molecular mimicry. It has to be bystander loss of tolerance. So again, these 2 points have consequences, and the consequences are, in the first case, perhaps there might be a point in trying immunosuppressants for people that have long COVID. At least the severe ones, because in many cases the heart symptoms go away on their own. The second point is that bystander loss of tolerance, as I was saying before, you just get really unlucky and activate a T cell or a B cell or both by the fact that you've infected a dendritic cell that's next to them with a virus. And that involves random activation of T cells or T cell dependent B cells. And you cannot predict what the specificity of that receptor is going to be. What that would mean is that you could have twins getting the same virus in the same house, and they would end up with completely different symptoms depending on that TCR and BCR specificity. So this offers a convincing, though of course it is speculative, a potential explanation for the extreme variability of long COVID-19 symptoms. And this was published earlier this year in Circulation. And with this, I should thank the people in my lab and the people in Gianluigi Condorelli's cardio lab. And thank you for listening, and I'll very happily take questions.
Thank you very much, Marinos. That was a great talk. Thanks a lot. I think Gustavo did answer most of the questions in the Q&A box. Okay. There's a message coming in there, Davo.
Just can't see you, Ben, so I don't know whether you want to switch on your camera.
Okay, there's a message that no, it's gone. Okay, maybe that was the message. The host has had to start the video or something. Yeah, maybe that's why. Yeah, so we can continue, right? The discussions. We have time because we plan for until 2:30.
So
And
can I
until
ask?
3:30. No, I was asking Davo whether we can continue the discussion.
We can continue as long as you want. So,
Okay.
and as long as the audience still hasn't deserted us. So it's completely up to you.
Is it okay for you, the speakers? Okay, and then we can go back to some of the questions that was addressed in the chat, and so that everybody can hear the answers. There was a question from Caroline that do we have any markers from inflammation stemming from epicardial adipose tissue? I think Gustavo has addressed it, but yeah, maybe we can just share that with everybody. Gustavo?
I'm not aware of any specific markers of cells coming specifically from that side. It would be great. What I know is that it's actually particularly enriched for B cells there. Whether these B cells there have specific affinity for a specific repertoire, I think this remains completely open. But Sabine Steffens in Munich, she's doing a lot of work on those tissues, and maybe you can find something on her work, but out of the top of my head, I'm not aware of any marker.
Yeah. Okay. There was also a question from someone else. No. We had a question from Constantina. Thank you for the nice presentations. Are there specific signals from cardiac cells, example cardiac myocyte, that trigger the immune response from other organs? Exactly, like explain.
I put a response in for that. There's work by Daniela Carnevale looking at the links between the cardiovascular system and the spleen, which could give some light into these questions, which I wrote in the answer section.
Yes. Okay. And we had a questions from anonymous person. Are we already aware of difference between men and women, and even differences between premenopausal and postmenopausal women regarding potential clinical trials? Yes, and I think, yes, Sophie?
That there are differences between men and women with respect to the immune system. This is well known and well addressed. And that, for example, with respect to interleukin-1 beta or SSS2 levels, they are higher in men as in women. But yeah, then after in the menopause, women then lose their protective effect, and also the immune system is then altered. Now, how or the problem still in clinical trials, whether it is now related to specific inflammatory strategies, anti-inflammatory strategies, or other heart failure medication, is often the inclusion of women. But this is a more let's say also an aspect which is has different kind of reasons. But there is also more and more awareness of that, and one is also seeing that this is more and more required. But one may not also forget that if one makes age-related comparisons, sometimes it is also different, or starts later in women as in men. So this as not, let's say, an excuse, but this is also one of the reasons, let's say, of in the clinical trials. But definitely one needs to take into account how strategies or therapies are differently in men versus women.
Okay. I was just wondering, yes?
I just wanted to add to that answer that in terms of the mechanisms, we know that there's the Tregs change in females once every 28 days in case there is fertilization. In mice, it's every 4 days. And so they go up and down, and there's a sort of, they have this, so Tregs have an estrogen responsive element upstream, and they expand in pregnancy, they collapse, and then they collapse further down in menopause. So anything that is T-cell dependent will be affected by this fluctuation of Tregs, which is there to enable pregnancy, which is the reason why we tend to consider pregnancy a lot in these things. And that fits with the differences that we get in the incidence and prevalence of anything that is inflammation related. The fact that this is not really considered in trials is, I think, as a social issue, a major problem that really has to start being addressed. Because if evolution works through the female reproductive system and its immune modulation, we're missing out a massive component of what makes our physiology the way it is. And this is something that as a society, we have to start addressing, I think.
I'm not sure if my answer was just to the person asking or everyone in the audience, but I would strongly recommend, there's this paper published this year on the American Journal of Physiology. It's called Guidelines on the Use of Sex and Gender in Cardiovascular Research. Charlotte Usselman and Mary Lindsay is also there. It's a wonderful. They really make the point very clear. Like, shame on us. But they propose how to tackle that in a feasible way for most research questions.
If you now mention that, I now would also like to mention that from the Heart Failure Association, now also recently published, pointing out the relevance and the differences with respect to diagnosis and management of women in heart failure. So, as I mentioned, I think the awareness is starting, yeah, but we need to continue.
Thank you. Yeah. The next question was on the, I think the T cells. Thanks for this super interesting talk. It's known how cardiac regenerative potential decrease over time with aging, but what about these Treg cells? I don't know those cells. Is it known if with aging they get less efficient? I know that T cells exhaustions has always been a major focus of in a CD8 T cells, but still isn't thought to happen also in CD4 T cells.
It's a wonderful question. There's a lot we don't know in aging. So there's this overall immunosenescence, what people call for lack of better term, it's poorly defined. What is aging? What is senescence? And there's huge variability in the population, right? What we know is that as we grow older, there's more T cells with a more effector phenotype, more memory, antigen experience phenotype. They can produce more cytokines. On the other hand, they can get into exhaustion, and then the opposite, you get they produce less cytokines. But most of the work is done on CD8 T cells, and there's a lot we know on cytomegalovirus infections in senescence. It's a big driver. There are work there from Joaquin Spiridopoulos in Newcastle, the group from Moro Garcia in Spain. They have beautiful work linking cytomegalovirus infection, T cell exhaustion, and cardiovascular diseases and heart failure. But how exactly this impacts post-infarction repair, I think that's big unknown. And the Treg cells, I think that's also a big unknown. There, in other fields, there's conflicting data on Tregs going down the hill or Tregs getting even more suppressive. And I say there's huge biological variability on the way we age, right? Just getting a cohort of 65 or 70-year-old, it doesn't mean we get a homogeneous population. That's the main challenge.
Mm-hmm. Thank you. And I think the last question was about those experiments on the day one mice that myself, I'm still impressed how they do that. But it was about, thank a lot for such an interesting presentation regarding the neonatal work. it was clear to me that adult T cells inhibit regeneration. What about the other way around? Did you test that if the neonatal T cells are beneficial in P7 or adult myocardial infarction?
It's a great thought experiment or Gedankenexperiment. We thought about it, but the challenge is 1-day-old mice, they don't have T cells around, at least in mice. So we cannot get an immune system from young mice and transfer them to adults to see how they will react. What I can tell is that if you infarct rag knockout mice that don't have T and B cells, when they're P4 or older, they still go for fibrosis, so they don't regenerate. So the lack of T cells doesn't mean you can regenerate forever, to be very clear. But whether these young T cells will be responsible for a better repair, that's unclear, and it's hard to tackle because there's so few T cells. And 1-day-old, they're more gamma delta T cells. You get some timing output at waves when they're born, at least in mice. But these experiments are taking a challenge due to the cell count.
Yes, I think, yeah. One more question from, I think all the questions being addressed.
I remember there was one question, it's now not anymore in the chat, but it was related to LVET, where they asked, okay, now showing that the inflammation went down by the impeller and the loading, how to reconcile with what the person has read related to LVET, that leads to inflammation. So first of all, LVET mainly is, of course, in patients really end-stage heart failure with already increased inflammation, where also the implantation per se can also induce inflammation, but also there our studies know that depending on the decrease of the inflammation, that the outcome differs. So if the inflammation goes down, then you have an improved outcome. But I want to make here the differentiation between the LVET in these end-stage patients, and here the example I brought, which was in a patient with a fulminant myocarditis, so where still the unloading really can help here maybe to lead to endogenous regenerative processes, because you don't have already a dilated final end-stage heart. Yeah, and so here again it depends on the time point, on the etiology of finally the heart, which affects then finally the protective effect of this unloading strategy.
Thank you. Massive thanks to all of you, to all the speakers, really. Thank you very much. That was the first time we, the ECI and MCI from the European session, are organizing such an event. Thanks to Davor for the support, right, since from the beginning. It's been some months that we contact you to talk about this. Like I said, it's a series of webinars. We'll be touching some other topic, but I have a feeling after this first webinar that we'll be back on the Immuno-Cardiology. It looked very interesting and exciting, a lot of things to learn and to consider definitely because it seems to be important regardless of the type of heart failure. So we all have to, focus on that. Thank you very much. And I think we see most of you at the ISHR meeting in Toulouse. Looking forward for that.
Thanks very much for the invite.
Thank you very much. Thank you very much. It's an honor to be here. Thank you.
Thank you.
Thank you for the speakers and the panelists on my behalf as well. So well done, everyone. You've kept the audience attentive for almost 2 hours. That's quite impressive.
Yes. Thank you very much.
Bye, everyone.
Thank you. Bye. Thank you.